don't know what the problem is, we can't address it appropriately for our patients. And so we ask a lot of questions. We take a look at their insurance and what their out-of-pocket responsibilities are, so that when we see that there's a significant out-of-pocket responsibility for the patient, we then can start looking at tools that can be put in place to address those problems. Tools like copay assistance programs or patient assistance programs, or if the patient has a Medicare plan and they're significantly underinsured with that plan, we start looking at, well, can we educate the patient on a better insurance option for them so that their out-of-pocket responsibilities become significantly less. So once again, is paying direct and focused attention to this issue. At times it's been difficult to try to convince the hospital system that this role is important, not only from the patient's perspective and assisting them, but also in protecting the provider from a financial standpoint. So effectively communicating with the different silos, the different disciplines within the hospital is very, very important. The more they understand what a financial navigator does in the oncology setting, the better. And so when I have a patient that is struggling with an out-of-pocket responsibility, or in other words, struggling with access to care, I want to make the appropriate people aware of that issue. So the physician communicating with them that there's a barrier in place, or it might be the RNs or the pharmacy that I'm communicating with. Once I've identified the problem and provided a solution for the problem, one of the effective tools that I have found that is very beneficial is to go back to the treatment team, to go back to the physician, pharmacy, and say, this is how I solved the problem. We now have access to care for the patient, and therefore now they become a believer in the program and will refer more and more patients to this type of service. So you would think that the easiest part of this process and this position would be to communicate within the different departments of the hospital. But my experience has been that this actually tends to be the most complicated part of the process. Each different silo, so the pharmacy department, the billing department, patient access, the multidisciplinary team, all speak different languages, and they all have different tasks and goals that they're trying to accomplish an overall goal, which is obviously to treat the patient. But they all have different responsibilities in this process, and they speak different languages. And it is so critical that the financial navigator or the financial advocate is the one that is speaking to all of these different departments, because they can speak the language of the patient, the language of the physician, the language of the billing department and pharmacy, and fill in the gaps when there are gaps that need to be filled in. Let me give you an example of this. So we had a patient, this was prior to me being in my role, we had a patient that got treated with a specific chemotherapy agent. It was a very expensive agent. When the patient came in for treatment, patient access took a look at the diagnosis and found that it was off-label. Well, they notified nobody that it was off-label, just that we were aware that it was that the treatments was not indicated for this disease. Well, when it came time for the billing of this, our billing department had over $100,000 in bills that couldn't be billed to the insurance company and was prepared to write it off. The nurse navigator in this situation had contacted the pharmaceutical company to get free drugs from the pharmaceutical company, but she never communicated with any of these departments that she had done so. So our billing department was prepared to write off $100,000 worth of care because communication did not occur with the appropriate different silos and the departments of the hospital. When in fact, what should have happened here is that the nurse navigator spoke with coding, spoke with patient access and with the pharmacy and with billing to make them aware that there is no need to write off this account. We can get free drugs from the pharmaceutical company that would cover the cost of the specific patient. So timing is so critical in this process. I would much rather deal with a problem than dealing with a crisis. And the crisis many times happens 3 months down the road when the bills start coming in. And unfortunately, once the bill is there and everything has been processed, some of the tools that I use to decrease that out-of-pocket responsibility has gone away. And so I will often meet with patients on the day of consult early on in the process and make them aware of here's what we're dealing with from a financial standpoint, and let's now start talking about some of the options that are available to you to decrease this out-of-pocket responsibility. So the psychological part of this is so important as well. We got to remember that when we're meeting with a patient who's newly diagnosed with a cancer diagnosis, they are fearful, they're overwhelmed, they're looking at their life and going, is it going to end? So when I walk into a room, I'm very cognizant of the fact that these patients are overwhelmed. And when you start thinking about Maslow's hierarchy of needs, if you come from that approach, the first thing that needs to be in place are the basic needs of the patient. So how will they get access to food? How will they get access to transportation? All of the basic needs need to be in place. The second level of the hierarchy of needs is security. How am I going to be able to pay my mortgage? How am I going to be able to put food on the table? And then, am I going to be well from a medical standpoint? Those issues need to be looked at and thought of when I'm meeting with the patient. So it's not uncommon that if I'm meeting with a patient, this patient is going to be experiencing some embarrassment and maybe even guilt about needing to ask for assistance. And so I make our patients very aware early on in the process that they're not alone in this process. They're not alone in needing to get a financial assistance, financial aid to get better access to their care. And so I'll often tell patients, I have a full-time job, and by the way, I have a colleague that has a full-time job addressing this very issue just for cancer patients. You're not alone. So that tends to help alleviate some of that guilt for some of our patients.